In your
No,
presentation,
only
no.
just only the
Just
references.
mention. Thank you, ma. Good presentation.
Next, we have Dr. REVATHY, KV, talking on goniotomy with a single-use KAHOOK blade. Short-term results.
Good morning, judges and dear audience. My topic is on goniotomy with a single-use KAHOOK dual blade short-term results. Combining microinvasive glaucoma surgery with cataract surgery has gained popularity due to its better safety profile. KAHOOK dual blade is a single-use ophthalmic surgical blade designed to perform ab-initio goniotomy and excision of the trabecular meshwork strip to restore the conventional aqueous outflow pathway. Our aim was to evaluate safety and efficacy of phacoemulsification with the KDB goniotomy in the treatment of mild to moderate primary open-angle glaucoma and primary angle closure glaucoma. It was a prospective observational study done at Tertiary Eye Care Center in Kerala with the 37 POAG and 20 PACG patient who had a glaucomatous field defect and visually significant cataract. Patient had an IOP of less than 30 mmHg and or were more than one anti-glaucoma medication. We excluded the secondary glaucoma patient with bleeding disorders and prior filtration surgeries. After collecting the demographic data, number and type of anti-glaucoma medications, Snellen's best corrected visual acuity, Goldman applanation tonometry, slit lamp biomicroscope examination was done, and Humphrey's visual field analyzer was used to categorize the glaucoma. All the surgeries were performed by a single experienced surgeon under periorbital anesthesia. After a standard emulsification with IOL implantation, the pupil was pharmacologically constricted and cohesive OVD was injected into the AC, and the KDB is inserted into the anterior chamber under direct gonioscopy, and the tip is guided into the nasal angle and inserted through the trabecular meshwork into the Slum's canal and advanced several clock hours. The same was repeated in the opposite direction. So each eye would be having a range of 110 to 140 degrees of trabecular meshwork excision. The postoperative care, the moxifloxacin eye drops QID for 1 week and prednisolone acetate for 4 weeks. AGM was continued postoperatively and discontinued as indicated by IOP at each visit. Intraoperative and postoperative complications were noted and IOP and number of AGM were noted. IOP reduction of more than or equal to 20% and or a reduction of 1 AGM was considered as success of the procedure. To analyze the changes of IOP over time, repeated measure ANOVA was performed and 2-case multiple comparison test was applied to identify specific differences. The results shown, PACG group 67.3 were the mean age, and in the PACG group 70% were females. In the POAG 68 was the mean age and 65% were female. Mean preoperative visual acuity was 0.7, which was improved to 0.08. A majority of the patients in the PACG and POAG group was having mild glaucoma. 75% in the PACG group and 86.5% in the POAG group had at least one AGM. The most common AGM was prostaglandin analog followed by beta blockers. The number of AGM before treatment in the PACG group was 1.4, which was reduced to 0.6, and in the POAG group was 1.2, which was reduced to 0.6, which was statistically significant after 6 months. In the IOP, the before treatment was 24 in the PACG group, which reduced to 15.2, and 24.3 in the POAG group, which reduced to 15.3 after 6 months. The percentage of IOP reduction of more than 20% from the baseline IOP was 95% in POAG group, PACG group, and 89.2 in the POAG group. The ultimate goal of glaucoma therapy is preservation of quality of life by reduced medication, improved ocular surface, and cost effectiveness and compliance. As a study done by Song et al., where they compared the phacogoniotomy and phacotrabeculectomy, have shown that comparable cumulative success rate, but the phacogoniotomy had a lower rate of postoperative complications and shorter surgery time with improved quality of life at 12 months. In our study, where we compared the POAG group with another similar study by Krishnamurthy et al., we have seen that the IOP reduced from 24.3 to 15.3, and the POAG, the AGM was reduced from 1.2 to 0.6, which was similar. In the PACG group, all the patients in the PACG group had undergone YAG laser peripheral iridotomy and had a mean IOP of 24 before surgery, and all of them were on AGM. The PACG group LPA deepened the angle and thus may lower IOP, but the procedure alone is not typically adequate for the long-term IOP control and for visual acuity improvement. In eyes with angle closure glaucoma, trabecular meshwork may be permanently dysfunctional by chronic synicalization, inflammation, and proliferation of the fibrous tissue. Thereby, combining the cataract extraction with the KDB goniotomy will further remove this dysfunctional trabecular meshwork, reducing the IOP further. This was our study group compared with another two studies by Doreraj et al. And Song et al., where they have done all goniosynoculitis also in along with the goniotomy. And our baseline IUP was 24, which reduced to 15.2 at 6 months, and AGM was 1.4, which reduced to 0.8. This was intergroup comparison. The intraoperative and postoperative day 1, hyphema and corneal edema was the notable complication of our study, which was managed conservatively and was cleared by week 1. Hyphema was the most common complication noted in studies by Doreraj et al. And Song et al. Conclusion: phacoemulsification with KDB is safe and effective for IOP control in both PACG and POAG group with visually significant cataract. The procedure reduced IOP and the need for AGM. Advantage of decreasing the number of topical AGM would be an improvement in compliance, reduction in the medical treatment cost, and decrease in the ocular surface toxicity. Limitation was, since it is an ongoing study, at present the current sample size is less and follow-up period is minimal. Thank you, and these are my references.
You are not compared with the cataract alone cases, no?
No, sir.
IOP reduction, because that also is expected, no?
Sir, it was
What I am asking is, if you compare this group with a cataract alone without a KDB.
Yes, sir. That reduction is in our studies have shown that reduction is much lesser when comparing with the KDB. No. So, since
I agree with the previous studies, but if you have another limb comparing that thing, that will give a more clarity.
Maybe we can consider, sir, because it's an ongoing study. The follow-up period is 2 years. We can include that also, like a separate arm. We can consider.
Whether the cost of KDB is affordable or the medicine?
Initially, we started with a single user, but when if we are not getting much patients, we did like
multiple use.
Yes, sir.
Okay, thank
Up to 3 we have done, sir.
Good, ma. But do you think this is going to be long-term permanent solution?
No, sir. The aim was in our
Your
study.
follow-up is less.
Yes, and in our study, the group was having mild glaucoma. Okay. So instead of giving them one medication, anyway they are undergoing cataract surgery. So this procedure reduces chance of medication-induced side effects in such patients, sir. So since the follow-up period is 2 years, we can manage how we can understand how their IOP is increasing over a period of time, whether it is a permanent solution or it is a temporary measure.
Whether they will need a anti-glaucoma surgery.
Yes, sir. Okay. Whether they need an AGM or an anti-glaucoma
surgery. Sir said no. Your result with the normal cataract, normal cataract reduces. Yes. But were all the cataracts the same type of procedure? SICS, phaco or anything?
Phaco. All the cataract was phaco.
Phaco. So basically, if you had compared phaco alone with this, yes, then it will show additional advantage of this, and long term will tell whether you will need for an alternative. Thank you.
Is there any difference in PACG and POAG groups with the KAHOOK?
Madam, up to this period, we have seen that the PACG group had an increased IOP reduction.
Like PACG behaved better way.
Yes,
madam. Than POAG.
Yes.
How much difference?
Madam, in POAG group, the 20% reduction was 89 in POAG group, but the 20% reduction from the baseline was 95% in PACG group. So, but the number is different, madam. Number was 20 in PACG, 37 in POAG.
The PACG, how long the patient is on medication, or what type of PACG? Directly going into PACG or after?
All patients were having chronic angle closure glaucoma, post-YAG laser PI, and was on at least one AGM.
Is there any difference in the subgroup analysis, PACG, synochial closure or creeping angle like that? You have not done.
Not done, madam.
Okay.
Thank you.